a medical ICU population of patients for 18 months in a 22-bed ICU. They looked at the frequency of diaphragmatic dysfunction defined as an excursion of less than 10 millimeters. Now, by this time, this definition is fairly well described in the literature. I also want to point out that when we attempt to reproduce some of these
Esta definición ya es bastante aceptada en la
share with us
literatura,
through the literature, we need to also abide
pero
by the
también
conditions
tenemos
that they
que
have. So, for example, in
ver
this case, they
qué
had the head of the
enfermedades
bed
tienen.
elevated 45 degrees. And so if we want to kind of reproduce these findings, we need to make sure we follow the same conditions. They identified a frequency of 2.2% of diaphragmatic dysfunction in their population. That was the prevalence. And what was interesting is the associated mortality with diaphragmatic dysfunction. And so that's a bit of an eye catcher there. So I want to move on now to the anatomy. So there are a couple of ways to assess this with ultrasound. Regardless of the technique, we want to look at the tissue, whether right here be the liver or on the left side the spleen, the diaphragm, the lung, and sometimes we'll see the chest wall or the abdominal wall, depending on the application of the technique. For example, here, if you take the approach where you want to look at the diaphragm from the side, then this is what you will appreciate. You'll appreciate the intercostal muscles. The lung will be moving in and out, and then the liver with the diaphragm obviously above the liver here. And we will look at its displacement, or that is the excursion or thickening later on. Now, this is a more common technique now where we're aiming at the dome of the diaphragm. Now, you notice that the probe is here. The first organ we hit here is actually the abdominal wall muscle, then the spleen, then the diaphragm, and at the very end is the lung. And so what we're looking for here is movement of the diaphragm towards the abdominal cavity, in this case the liver, and then back to baseline. So this is the actual ultrasound image. This is more of like a cartoon image of what it would look like under M mode, which is the technique that's recommended. Here in this image, you can see the first on A. It's a volunteer who is spontaneously breathing and has fantastic excursion. The movement of the diaphragm moves quite a bit, and so that's what we appreciate. On the other hand, and it depends, you obviously want to follow the diaphragm. Here we have one where it's less than 10 millimeters, which is consistent with dysfunction of the diaphragm. And then lastly, you have here paradoxical. So when the patient takes a deep breath, the diaphragm moves in the opposite direction. And this is what we typically see with somebody who has an injury of the phrenic nerve or hemidiaphragm. Speaking of hemidiaphragms and phrenic nerve injury, I want to talk about this particular paper because I have seen this described in some of the courses that are available. And that is, aside from applying the particular techniques as the authors of the paper describe, we also want to apply it in the appropriate patient population. But this these authors employed this in cardiac surgery patients. And if you read the paper, there was a strong interest in recognizing phrenic nerve injury. So they were actually looking for best excursion. If it was less than 25 millimeters, this predicted failure of weaning from the mechanical ventilator. But for example, we wouldn't want to apply this technique on somebody who has chronic respiratory disease, and hence that's why they're struggling weaning from the ventilator. However, in a group of cardiac surgery patients or possibly perioperative patients, this may be a more appropriate technique. So if you see this, this is where this comes from. What's I think more common is this definition and application where this group of investigators looked with the patients in a supine position, again, not at 45 degrees, but in a supine position. They were looking at the excursion of less than 10 millimeters during a spontaneous breathing trial. And if it was less than 10, they were able to identify failure from weaning from the mechanical ventilator. What they did is they took 6 measures, they took the average, and that is the measure that they recorded. the area under the curve, or the ROC, gave a power, a predictive value of 0.61, which is, it's good, but, it's pretty close to 0.5, which it doesn't really give us a whole lot of, there's not a whole lot of predictive value there. I'm going to move next to this particular publication by this group of investigators, and they looked at a technique that I think we employ more often now, and that is looking at diaphragmatic thickness. And what they define is that the thickness is less than 30%. That predicts failure from weaning from the mechanical ventilator. So the way they took this measure is they took the thickness of the diaphragm at end inspiration and then at end expiration. So this is the thicker, this is less than 2, and they divided by the end expiratory thickness. So these two are the same measures here. And this is what we're looking at. Here's the ultrasound image, and this is the cartoon picture where you would look at end inspiration and end expiration, and that's where you take these measures. Here is an ultrasound image just kind of comparing a measure on a patient who doesn't have a significant difference in thickening versus a patient who has a significant difference in thickening here. When you look at the ability to distinguish those who failed extubation and those who successfully weaned from the mechanical ventilator, it's a little difficult to tease them out by setting a particular bar. In fact, and this is the one that correlates with the area under the curve. Just to remind ourselves, the closer you get to the red line, the less valuable that particular technique is to reach the, whether it be the diagnosis or the, in this case, identify those who are going to wean from the mechanical ventilator. In this particular study, where they looked at the change in thickness of less than or greater than 30%, you notice that they're further away, so there's enhancement of sensitivity and specificity, specifically specificity in this particular study. And here you notice that we're allowed, at 30%, we're allowed to distinguish those who successfully extubate from those who don't a little bit better than, say, the other one. So just to compare that, this is the less than 10 millimeter, this is the less than 30% thickness. And so, when you compare these side by side, this seems to have a little bit better predictive power to identify those patients. I do want to just finish in saying there is not only just applying the particular technique under those conditions and in the appropriate patient population, but we also want to look at other things that we do that may influence the particular technique we're applying. And in this case, it's the application of pressure support and how it affects thickness during a spontaneous breathing trial. And in this particular study, the investigators noted that if you give more pressure support, in this case 15 is this one, you notice that you move closer to the red line. And so you start losing your predictive power. So if you give people more positive pressure or pressure support ventilation, in this case 15/5, it may look like your patient's going to wean from the mechanical ventilator by thickness, but actually the patients will fail. Now, the difference between 10 and 5 is not significant, at least not reported by the investigators on that publication, but 15 definitely starts moving away from a norm. So these are the conclusions of this brief presentation. Is diaphragmatic dysfunction is defined as an excursion less than 10 millimeters. End expiratory excursion of less than 10 millimeters is an indicator to wean from the mechanical ventilator with an ROC of 0.61. I think it's important to recognize that. I think we're moving on to the next presentation. I lost my slides. Okay. Sorry, I'm losing my slides here. I guess we're back to.
Just need Dr. Hernandez's last slide. Or feel free to talk through your slide, Tony.
Okay, very good. So the main thing, again, it's just the same conclusions, is that the thickness in the diaphragm appears to be a stronger indicator with an ROC of 0.79 and avoid pressure support above 10 centimeters of water during a spontaneous breathing trial when applying either of these techniques. And that is actually the last lecture. The last one was just a thank you. So I thank you all for the invitation.
Excellent. Thank you, Tony. What I'd like to do is just go a touch out of order and ask Dr. Park to take us through extracorporeal support. Dr. Murphy has a bit of a clinical issue at the moment, so we'll see if we can recover him in a few moments.
Actually, sorry, I can.
Oh, you're good? Great, in which case we will proceed with Dr. Murphy and quality assessment of mechanical ventilation. That is superb.
Apologies. Terrific. Thank you for the opportunity. Can you see my slide?
I can.
Great. Terrific. So we're going to spend a few minutes talking about some conceptual models that underlie the quality of care that we're providing for mechanically ventilated patients. How do we take the information that was shared and that we see in our evidence that Antonio and many others share, how do we make sure that we're reliably delivering that for our patients? I wanted to talk about quality measures and some specific desirable attributes of that, as well as then some example measures specifically related to mechanical ventilation and patients who are receiving mechanical ventilation. First, we spend a fair amount of time and effort understanding disease biology with our basic science. We then spend additional effort identifying effective therapies such as ultrasound, lung protective ventilation, and a variety of other clinical innovations. And then we expect that that's going to translate into improved health for our patients on an individual and population level. However, we've found that there is frequently a gap between the clinical research and actually delivering that effectively. And quality improvement, quality assessment, knowledge translation helps us to ensure that therapies are used safely and effectively in the larger populations. Several years ago, Abid Sanabadian came and developed a conceptual model of structure, process, and outcome that underlies many of our approaches to assessing quality. I wanted to go over that with the group. First, there is structure, and those are the conditions which underlie the care that is being provided. This may be the building, the ventilator. This may be the number and qualifications of the staff and the providers who are taking care of patients. It may be how we organize ourselves and what are the different protocols and ways that we expect that we're going to be taking care of patients. And then process is what the actual delivery of care itself. It's the diagnosis, treatment, education, prevention, rehab for patients. It's in the real time what's going on. And then outcomes are the result of the care that we're providing. So mortality and improvements in mortality, improvements in functional status, things like that. We can then marry this classic definition or this classical model into a newer, more value-focused equation. So we have outcomes, and then we add in that over cost of delivering care, and then we yield into what kind of value of the care that we're providing for our ventilated patients. Now, there are things that we can measure, and there are things that we can influence. As a clinician, when I am at the bedside, I can directly influence the process of care. I can work to diagnose things. I can work to treat patients. I can educate them. However, as a medical director in my ICU or in other more administrative capacities, I cannot directly influence the process of care. Rather, I need to set up the structure to support that care delivery consistently for our patients. I also can influence the cost as well. Measurement-wise, there are a number of points that I can influence or that I can look at. I can look at the structure, I can look at the process, I can look at the outcomes, and then I can also incidentally look at the cost as well. So what are the desirable measures or desirable attributes of the measures that we want to be looking at. We want to be looking at, are these important? Are they feasible? Are they valid? And are they actionable? So as we're going through and seeing what are the different things we can look at, this is kind of a report card or a scorecard for us to see how does this measure, this potential measure, stack up. So does the measure represent something that's important to clinicians and patients in the ICU? Is there room for improvement? Is this an important thing for us to look at? Am I able to measure it? Or is it too hard for me to measure? What's that feasibility? How valid is it from an internal perspective? Does it convey what we want it to convey? How consistent are we able to measure that? If there's lots of variation in how we measure something, that may reflect more the measure than the actual quality of the care that we're providing. And also, how does that share over, how does that generalize over larger populations? As we're dealing with a global conference, how do we make sure that one metric in one ICU is comparable in some way to those across in another hospital or another ICU across the country or across the world? And then is there an action that we can execute that can influence this intervention, or that can influence this metric? Some structure examples. So there's a lot of attention, rightfully so, around the ABCDEF bundle. There has been, for a longer period of time, the lung protective ventilation protocol and evaluating how do we provide mechanical ventilation for patients with respiratory failure. This can commonly be seen as, do you have policies or protocols, do you have structures in place that support those ends? So a recent study published in Critical Care Medicine this year reviewed a global survey which demonstrated there is actually some success in our having policies and protocols in their sample for treating pain and spontaneous breathing trials and sedation management. However, more room for improvement when it comes to delirium management, recognizing and evaluating ICU-acquired weakness, and opening visiting hours for family engagement. So this, do you have a policy or protocol in place, can help us to understand a little bit, or one aspect of the structure as we're trying to build towards higher quality care for our patients. When we then look at process examples, this moves to what are we actually doing for those patients. So neurologically, we may be thinking about, for pain, agitation, and delirium, we may be thinking about the percent of patient days in which pain was assessed 6 or more times, or sedation, or delirium. From a pulmonary system perspective, we may want to see what's the percentage of ventilator days that had a spontaneous awakening and breathing screening done. Looking at lung protective ventilation, what's the percentage of ventilator days on which patients with ARDS, or those who don't have ARDS as well, receive the tidal volume that meets certain criteria in terms of tidal volume and plateau pressure. These can be taken from the original studies that were looking at effectiveness. However, they may require some adjustments as we're dealing with things in a more real-life non-study environment. Examples of this, so on the left we see a composite chart over time, where we see the in blue the number of patient days where we've had 6 or more assessments. This was an intervention in some of our ICUs where we saw initially very low frequency of documenting pain as frequently as we wanted to, implementing an intervention, and that's continuing then to rise, as well as documenting the control of pain. And we were able to see that in a composite picture that was very effective for our providers and staff to be able to see. On the right is a depiction of how we provide lung protective ventilation. So this is a snapshot on the best values in the first day of mechanical ventilation for patients with ARDS. And on the x-axis, we have tidal volume in milliliters per kilogram predicted body weight, and we have plateau pressure on the y-axis. We would like all of our patients to be in the bottom left corner, in the bottom left box, where they would totally meet those criteria. We see, however, we do have room for improvement in this cohort of patients, where we see, perhaps because of lung compliance, we have patients who are being ventilated at a higher tidal volume than we would initially like. However, their plateau pressure is not as high, and they're able to compensate. In the top left box, we see patients who presumably have quite stiff lungs, and those are folks that perhaps that Pauline can help us out in our next talk when we're talking about ECMO. And then in the top right, again, we have patients who are receiving higher ventilation, higher tidal volumes, and higher plateau pressures. So presumably, we need to be able to look and see how are we doing with setting our tidal volumes, and then how are we doing with adjusting our tidal volumes in response to elevations in plateau pressures. So this can help to drive change and help our clinicians in the front line evaluate what is our actual performance for these processes of care. When we look at outcome examples, we certainly want to look at global things like unadjusted or adjusted hospital mortality. And we want to look at ICU readmissions. We want to consider pain. How well have we not only assessed it, but how well have we controlled that pain? We can look from a pulmonary perspective at the number of new onset ARDS patients per 1,000 vent days, on the number of unplanned extubations per 1,000 vent days. So different ways that we can evaluate the outcomes of our different changes and interventions to improve our care. Some quick examples of this: there was a nice study recently, again, in critical care medicine, looking at ventilator-associated pneumonia, and they were able to display on the left the decrease in ventilator-associated pneumonias per 1,000 ventilator days, both in the solid line across all hospitals as well as in subsets of hospitals. So that's a much larger cohort, multiple hospitals participating. When we then look on an individual hospital level, we can move towards the right, and we see a run chart of central line associated bloodstream infections, or CLABSI rate. And we see that over time, we see the actual rate, we see what's actually observed, as well as the average kind of running mean of that performance to try to smooth that out over time. As you have a smaller sample size and you go into smaller and smaller units, the variation of having one infection can have a profound effect on your rate overall. So we can then transition, if these are rare events, we certainly want them to be, it can be helpful in smaller groups, smaller individual units, to transition perhaps to time since last event. And in the bottom I have two ways that we've depicted that in individual units, one with a PowerPoint sort of banner saying how many weeks has it been since the last slide, since the last bloodstream infection. And then we have, all the way on the right, we do see someone actually holding a sign, which has helped us actually a fair amount with clinician engagement. And so how we're able to depict that, both people saying this is where this is how we're doing with our rates since our time since last infection. So in summary, quality measures should reflect our overall objectives and the steps to achieve those objectives. We have to make sure that they are aligned. These measures should be important, feasible, and valid, and actionable. We do need to assess quality in mechanical ventilation. This is imperfect, but we are getting better with this as science is advancing. We need additional work to develop a core set of quality measures globally. So I thank you for your time and attention. Happy to pass this off.
Awesome. Thank you so very much, David. We're going to continue this session now, moving to Pauline Park. And Pauline will tell us all about extracorporeal support when our quality mechanical ventilation doesn't quite do what we'd like it to do. Pauline?
Thanks, Lou. Can you see the slides?
I can.
Okay, great. I want to thank the organizers of the World Day of the Critical Lung and Society for Critical Care Medicine. I'm going to go over in a 12 minutes, I'm going to try to go over some of the overview on extracorporeal techniques for pulmonary rescue, including where does it fit into your care algorithm, what are the components of the ECMO pump itself, the evidence behind its use, and some discussion of indications and management. And although there's plenty to discuss further, we can review in the Q&A. So I want to give the shout out to Bob Bartlett at Michigan here. He's the father of respiratory ECMO, and this photo really shows the impact that he has had. The medical student that he is enrobing in the white coat ceremony was placed on ECMO as a neonate, as a life-saving measure, and she subsequently grew up to go to college, work in the ECMO laboratory, and attend medical school here at Michigan. So the two things I want to say is that ECMO it's a deceptively simple technology of great interest globally in respiratory failure, and it requires not just knowledge of the mechanics itself, but also strong institutional support and ongoing program reappraisal to really integrate it into a care program. So to go over, it provides a sustained, often life-saving, life-supported extended cardiopulmonary bypass for both cardiac or pulmonary failure. And it's important to note that ECMO itself does not treat the underlying pathology. And what it really does is, by giving support, it provides time at a price. So you are able to give additional cardiorespiratory support, and for every minute that you continue, every hour you continue on support, you risk complications of the technique. As an overview, as Dave alluded to, current treatment strategies in ARDS in 2017 really still focus on this diagram that was put out at the time, the Berlin criteria. We look at prevention or early treatment for ARDS before the inciting event. We can look at open lung ventilation, though I think that there's some questions that were raised by the recent ART trial. We can look at driving pressure as per Amato, or transpulmonary pressure with esophageal pressure monitoring as Denny Talmore's trial is being evaluated. And then we can look at neuromuscular blockade as per Accurasis. There's a confirmatory ROSE trial in progress by the Pedal Network Group. And then, as Mark will be talking about after this, we have to always consider long-term outcomes after severe illness. So what we're talking about with ECMO is really focused on the patients with severe ARDS with a PF ratio of less than 100. And the consideration is whether or not we should be using ECMO solely as a rescue treatment when all other modalities have failed, including prone positioning, neuromuscular blockade, and ventilator management, or whether we should be considered using it for early treatment to spare the lung from toxic mechanical ventilation. I don't have the answers to those questions today, but I can go over some of the controversies. So in short, what is ECMO? It's really a mechanical system for extended cardiopulmonary bypass. There's a pump system, which is most commonly in adults now, a centrifugal pump, or there can be a roller pump, or if you use arterial-venous communication, then you can use pumpless ECMO. There's an oxygenator, which is a polymethyl pentene hollow fiber oxygenator, most commonly. There are cannulae, which are used to drain the blood and perfuse the circuit and then return it to the native circulation, that are arterial or venous for the inflow and venous for the return. And then the circuit itself, which is the tubing, which may be coated or uncoated. And those are the four main components that make up the pump. There is no reservoir and there is no air exposure for the circulating blood. The basic physiology is that oxygen delivery is limited by the content carried by the blood and the flow provided by the pump circuit. In general, the circuit flow in adult is limited only by the amount of venous drainage that you can obtain. Carbon dioxide removal or ventilation is limited by the sweep flow of gas passing by the oxygenator. Any contribution of native lung gas exchange can vary based on the patient's own respiratory status, the adjunctive mechanical ventilation, and the circulatory status. So most commonly for respiratory failure, we use veno-venous ECMO that refers to drainage from the venous side through the pump and oxygenator and then returned to the venous side. This can be accomplished via a single site dual lumen cannula, which is depicted in this picture or this diagram, or dual site drainage, which would involve using a femoral cannula instead of the inferior vena cannula. So the blood will return from the venous side and then enter the circuit. Pump, you can add an optional hemofilter in the case of renal failure. There's anticoagulation added into the circuit to maintain biocompatibility. Blood passes through the oxygenator and then returns arterialized or oxygenated into the right ventricle on the venous side. So the circuit is in parallel with the pulmonary circulation. There's mixing of the oxygenated blood from the circuit and any deoxygenated blood that's also passing through the native pulmonary circulation. This is a picture of the cannula. Because if you're going to give support for hypoxia, you generally require higher flows than if you're just doing ventilation support. So this is about a 29 French cannula, I think. But it gets quite large. It's placed in the right IJ. And the photograph of it, the chest x-ray of it, will appear in this fashion. It's a large cannula coming through the jugular system. There's a drainage will be by cable from the inferior vena cava and from the superior vena cava, and arterialized return will be through the right atrium. Note that the lungs are intensely collapsed in this case, and that's related not just to the underlying pulmonary disease, but to the ventilator management, because as lung protective ventilation is initiated, the ECMO does not change the underlying compliance of the lung, and as such, there's often collapse and deep atelectasis. I mentioned the major complication on ECMO is related to that biomaterial blood interface, and that would be the requirement for anticoagulation leading to thrombotic and hemorrhagic complications. This is the picture that we never want to see, which is the picture of the patient who has the cannula. You can see them to the side on the right side, but there's a large intracranial hemorrhage, and this is a devastating complication and associated with increased mortality in ECMO. We like to think that modern-day ECMO and critical care has brought progress, especially for this complication, but they also, data from 1990 through 2016 suggests that the incidence of major CNS hemorrhage remains essentially unchanged in the 3 to 5% range, though there are more survivors reported in the last 5 years. Well, that is, what is ECMO, what can be accomplished, and what are the risks? What's the evidence that we can use it? Briefly, this is the majority of it. There are 3 main randomized controlled trials and 1 that is pending reporting now. And they both mostly show the same thing through the decades. This is the original Zapol study from the 70s. This is Alan Morris's study of ventilation versus ECMO in the 80s. And this is the Kaplan-Meier from the Caesar trial that was published in the 2000s. And you can see that overall, these are survival curves, so you can see that overall survival has improved greatly over the decades, from 9 and 10% in the treatment and control arms in the 70s to the 30% range, and now we're into the 50-60% range. But there's not substantial difference between the control ventilation and the ECMO arms in the first 2 trials, but there is suggestion that there's a 30% mortality reduction on transfer to a specialized center in the UK. Dr. Mickelson, who's speaking next, did a meta-analysis of these trials, and it's difficult to interpret. I think Caesar trial, to be fair, they were stopped early for efficacy, and so criticisms exist regarding whether or not every patient received ECMO or not, or whether or not the control arm, since it was a pragmatic trial, did not have closely controlled ventilation. But their findings did show that there was mortality reduction. An ongoing or just completed randomized trial is the Aeolia trial from France. We're waiting for their results now. They've completed enrolling over 200 patients across the globe, and I have heard some initial rumors, but waiting final results of this study. So in the absence of strong randomized controlled data, what we have is largely observational data primarily since 2009. I think the flu data you can see here, that this is a graph of all from the ELSA registry showing the use of extracorporeal support in the neonatal, pediatric, and adult populations, and the growth in ECMO is largely driven by a growth in adult respiratory failure since 2009, when the H1N1 pandemic attack hit the globe. Across the International ELSA Society, the registry report suggests that there's over almost 14,000 cases to date, and the overall survival in adults is 58% for all comers, for all indications. Observational data, this is a trial from the UK in ECMO, and where they compared patients who were referred for ECMO for influenza to patients who were not referred. They were in a concurrent observational study for influenza, and using propensity score matching in 3 different methods, they suggested that patients who were referred for ECMO had improved survival compared to those who were not referred for ECMO. There were 80 patients referred for ECMO, which 69 of them actually received extracorporeal support. Their overall hospital mortality was 27.5%. Reviewing a similar trial in France, this is TISAM, again showing, comparing a cohort of patients who received ECMO and a propensity-matched cohort who did not receive ECMO. One thing they did note, it's in their supplement, depending on the statistical technique used, you can have a substantial or significant difference between patients who received ECMO and those who did not. So they were only able to match less than half of the patients receiving ECMO, I think primarily because the indications are different, the patients are younger. It's not the same population as the general ARDS population. And so you can see that statistically the impact of the therapy on mortality can be shown to be either none or substantial. Observationally, what are we doing currently? In the recent lung safe study, out of 29,000 admissions across the world, almost 4,500 with acute hypoxic respiratory failure. Number drops to about 2,800 with ARDS. Of those, only 48 received ECMO. That's somewhere in the 5% or less range. Seeing similar findings in the U.S. trial we just completed in October. Looks like about 2,000 plus patients with moderate to severe ARDS, and the ECMO rate will be under 5%. So the application of the technique is life-saving, it's dramatic, it's in the patients who are probably the sickest, but it's not really for the majority of patients with respiratory failure. I'm going to go on, though, to say that there are indications that the patients who are made at the cohort determining the Berlin criteria, and in the lung safe cohort, patients with severe ARDS, and that is presenting with a PF of less than 100, have substantial mortality still 45 to 46% in those 2 groups. And within this high mortality subset, as we continue with all the different critical care modalities that we have, ECMO should be considered to be an option. So when would we use ECMO? What are the indications? Because there are patients with refractory hypoxemia who still die of primary single system failure, and those patients that may be salvageable should be considered. So the indications are not firm, but in general, patients with a high risk of death, you can use the Murray Lung Injury Score. Patients who are refractory, you can use the short and long criteria that are used in Aeolia. There are specific hypoxemia targets. Patients who have reversible or refractory cardiopulmonary failure, and they don't have any contraindications, which would include things that are not irreversible. Again, ECMO is a support. It is not a treatment. So there may be relative contraindications for age, malignancy, immunosuppression, patients who presented with CPR, they already have a bleeding risk, they have severe pulmonary hypertension, or on prolonged mechanical ventilation prior to ECMO, and that would be classically more than 1 week. patients who might benefit, who would we put on? You can use the scoring system. There's the multiple predictive scores described. They're primarily derived retrospectively from cohorts of patients who are on ECMO, so the comparator is missing often, but they can give you an idea of what your patient's risk might be compared to other patients who are already placed on ECMO. This is just one example. This is the RESP score from Australia, and you can plug in, you can see on the side here, it will let you plug in risk factors for age, immunocompromise, mechanical ventilation, etc. Who should do it? Briefly, utilization of adult respiratory ECMO, as we saw, the overall use in adults has increased. There is probably a volume outcome relationship for adult respiratory ECMO. You can see here based on number of cases overall, there is a decreasing mortality for the centers that do more ECMO, but there's probably substantial confounding by indication and selection bias. If you do a lot of ECMO, there may, as opposed to doing less ECMO, is there a question of who you're putting on? The final position paper should be they're recommending about 20 cases per year with an overall program with a minimum of 12 for adult respiratory failure. I'm going to wrap up briefly. These are very quick slides here that patient management really compared to original what we would call ECMO 1 or classic ECMO versus what we were trying to aim for in 2017. It parallels current critical care in that we are probably moving towards more awake patients with spontaneous breathing, away from deep sedation, the question of early tracheostomy to facilitate ventilator weaning and actual extubation is possible. The bedside personnel have gone from a specialist at the bedside 24/7 to being incorporated in ICU care with nursing. Lung recruitment is probably still a watch and wait. That means that when you have that dense infiltrate and atelectasis on the chest x-ray, we wait for that x-ray to clear and then begin recruitment. And then the hope is that bleeding complications being applied in many areas, including CPR resuscitation in awake patients, and bridge to lung transplant. There's also indications for sepsis and trauma, and DCD and neonatal. So I think I'm going to wrap up here and just say thank you very much for the opportunity to speak, and I'll be happy to take questions.
Awesome. Thank you, Dr. Park. Now, you have described rescue therapy for a truly critically ill group of patients. The sequelae of that recovery and that care process is what Dr. Michelson is going to tell us about next. So, Mark, I will turn it over to you to talk to us about acute respiratory failure as a precursor to the post-intensive care syndrome.
Thank you, Lou. First, just to confirm that you can see my slides and hear me?
I can, and we can.
Awesome. So first, thanks to Dr. Kaplan and the rest of the team for putting this together. It's a true opportunity to have the opportunity to speak. And good morning, afternoon, or evening to all of those who are listening or joining across the world. So as Pauline was just speaking about, acute respiratory failure is common, and even in the most advanced cases, the issue of survivorship has emerged in the last several years in terms of the frequency with which our patients, even those who are most severely ill, are able to survive the intensive care unit. As an example, the community provides additional support, not just in the intensive care unit, but continuing thereafter. There's also a less sense of control over one's life that often drives these issues. We've also recognized the economic implications, specifically that there's a negative impact on employment, meaning either one works less or it becomes unemployed because of the needs of their loved ones and the need to care for their loved ones at home. So together, in the United States alone, there are nearly 6 million ICU admissions. What we've learned, even for the most sick, including those who have ARDS, those who even go on to ECMO, 85% of these patients will survive. Long-term impairment overall is common, it's under-recognized, it's costly, and the impact extends beyond survivors. So now that we have a better understanding of what patients are experiencing, an issue is, or a question is, To what degree are these issues of survivorship addressed? The reality is, when examined, it's unfortunately all too common that these issues are not addressed. We need to ask ourselves, why not? Is it because we don't have the time, we don't have the knowledge, or we don't have the comfort? It's probably a little bit of all of them. At the end, I'll highlight an opportunity to potentially leverage to increase awareness by sharing information at the time of an ICU admission. It was over 10 years ago where Derek Angus and Jean Carlet asked us to rethink critical care, to look beyond the ICU, beyond the ward, into the future beyond, to understand what these patients are experiencing and what we can do to improve care delivery for them. I'm going to spend the remainder of the time linking what we can do in the ICU and a little bit beyond to improve outcomes in the intermediate and longer term. This study here by Lee and colleagues is a phenomenal story of what patients, when they had the opportunity to share their own voice, expressed. After the ICU, there's a period of stabilization on the ward. There's the importance and requirement to prepare patients and their loved ones for what's to come. And then there's a period of adjustment. But to focus on the ICU and the care delivery that we can provide, David highlighted that quality measures based on evidence that we can apply in our intensive care units begin with the ABCDEF bundle. And just to highlight some of the facts that we've learned through these landmark trials. First, we found that by interrupting sedation, patients could get off the ventilator faster, get out of the hospital faster. We see an improvement in survival, although it did not reach statistical significance, and patients can get home. That's a fundamentally important point which often is overlooked. The ability by care provisions in the ICU to get home, to get back towards independence. We will return to that fact when we talk about early ambulation. When awakening was paired or coordinated with spontaneous breathing trials, you see long-term mortality improves, mediated by getting off the ventilator faster. When it comes to the D, in preventing delirium, there's an important need to minimize sedation. We've recognized study after study in the last 5 years that the duration of delirium is associated with long-term cognitive impairment, both medical and surgically critically ill patients. This study by Pratik Pandarapandi is one to remember. On the right, what we see is a visual depiction that for patients who are started on benzodiazepine infusion at 1 milligram an hour, which would be a cumulative dose of 24 milligrams in a day, nearly all of these patients will transition to delirium. It's evidence that highlights that our care provisions, our sedation provisions, can lead to long-term harm, the importance of minimizing sedation and preventing delirium. In regards to the E, pairing engagement and early mobilization, there are a number of benefits, both now in medical as well as surgical patients, that have been realized, reducing delirium days, reducing duration of ventilation, length of stay, functional outcomes, and even in one study, reducing the rate of hospital readmissions in Pete Morris's important work. Providing the ICU diary, it's now recommended within 2017 family-centered care guidelines, the impact that we can have by providing an ICU diary. For patients that have delusions, the ability to bring their memories together, both by engaging the patient's loved ones and sharing with them what they did experience and what they did not experience, the opportunity to reduce post-traumatic stress disorder has been demonstrated in several different studies. And then this is an additional F for your consideration. When we think about what we can do to mitigate long-term impairment in cognition and mental health, there's the question of fuel. The brain requires the fuel provided by continuous glucose and oxygen delivery. And so it's not surprising that when studied, hypotension, hypoperfusion through the original conservative fluid management strategy, hypoxemia, and hypoglycemia have each been implicated as important considerations to avoid when caring for patients in our ICU to prevent long-term impairment. And while we spend a fair amount of time talking about the losses that patients may incur, it's also important to promote hope. When studied, we were surprised to find, but it was in many ways a landmark finding, that resilience, even amongst patients who have experienced anxiety, depression, physical impairment, is actually the norm. As the American Psychological Association put it, resilience amongst humans is ordinary. It's not extraordinary. And so how moving forward within our care delivery in the ICUs and beyond can we promote a culture of resilience amongst our survivors and their loved ones? Well, it begins by listening to the voices of our survivors, by increasing awareness through important educational opportunities like this one afforded to us, by educating and engaging patients and their caregivers, by implementing and carrying out in all of our patients the ABCDEF bundle, and by working together from ICU to floor to outpatient providers to improve care coordination. Through the Society of Critical Care Medicine's Thrive initiative, recognizing the importance of support, the lack in some instances of support afterwards, we recognized and designed and implemented an innovative network of in-person peer support groups. It's now nearly 20 sites across the world that are participating and leading in this efforts. Most recently, we've added a post-ICU clinic collaborative, better understand the needs of these patients and to better, in 2016, with the next round of peer support collaborative sites to be named, these are the sites where the peer support collaboratives have been launched. More locally, bringing it home to our own patients and recognizing the study by Sush Govindan and Jack Iwashina that recognize that even those like myself, I need to acknowledge, that recognizes the importance of this. On a day-to-day basis, I wasn't sharing the information with the patients that we need to. And so we built a website, you can find it at the bottom left, and in it is a tab that says Life After Critical Illness. We're sharing this with our patients because we recognize that without adequate education and preparation, our patients and their loved ones will not be prepared for what is coming in the future. Together, that's what this work is about. It is identifying and providing the best care in the ICU and bringing meaning and life back to the survivors of critical illness. With that, I'll say thank you for the opportunity to speak here again, acknowledgement to colleagues, collaborators across the world, and I look forward to taking any questions that you have. Thank you very much.
Perfect. Awesome. Now we have the most wonderful opportunity to ask questions. If you have things that you'd like to know, please feel free to send them by chat. But I will start with Dr. Prakash. Dr. Prakash, you are at the burgeoning University of Chicago Trauma Center, and you are developing policies, protocols, and guidelines for how that center will work. Can you talk about whether or not you are deploying a quality assessment program for mechanical ventilation, and if it's been challenging, what those barriers have been and how you've overcome them?
Thanks, Dr. Kaplan. In short, I wanted to thank you, the organizers, and all the discussants for the opportunity to participate in the World Day of the Critical Lung. This is really exciting. Yes, here at the University of Chicago, we are trying to get the institution ready to open up on May 1st to become a level 1 adult trauma center. And we are heavily involved in writing policies and procedures to not only get the institution trauma ready, but also to have the intensive care support that we're going to need for a large volume of critically ill patients that will be coming. You know, right now there are not, as the institution stands, there isn't a significant amount of policies within the surgical intensive care unit for ventilator weaning. So I think it's one of our important jobs is to try to develop that. You know, one of the questions I have is what is the best way to try to start that from scratch? What are the main factors that we should be looking at, and what are some of the more advanced things that we can move towards to really make this part of the future care of critically ill patients?
Perfect, thank you. Dr. Smith, you are at Grady, where there is no shortage of injury, and in particular gunshot wounds. Can you share a perspective on post-intensive care syndrome and retained bullet fragments in survivors of severe injury?
Yes, hi, and thank you for the opportunity. As you mentioned, we're a high volume level 1 trauma center, and one of the things that I'm very interested in is mental illness after traumatic injury. We know that it can be a risk factor, but it also can be a consequence. And how does that relate to our patients that are in the ICU? We're still really trying to figure that out. I do have a special interest in retained bullets and individuals who have suffered from gunshot wounds. We know that they have a high likelihood of developing PTSD, depression, anxiety, and so forth. What we're finding is that a subgroup of these individuals, whether they've been in the ICU, intubated for a prolonged period of time or not, if they have retained bullets, they are likely to have more depressive symptoms. We think that it might be related to the ongoing, kind of the persistent thought that the injury has occurred because they can feel a bullet or they know a bullet is inside them. But we are very interested in post-intensive care syndrome here. Currently, we do not have a good SBIRT model, which is screening, brief intervention, or referral to treatment. And so my questions for Dr. Michelson is, how do you establish a screening and brief intervention for post-intensive care syndrome when one is not established? But I do want to thank all of the discussants and the lecturers. This has been a great forum, and I'm happy to answer any further questions.
Mark, would you like to take that one?
Sure. Can you hear me?
We can.
Great. So thanks for the question. I think in general right now, one of the points that is important to take into consideration is that while we work on screening, the next iteration of the Thrive Task Force is going to be focused on sharing best practices and guidelines in terms of screening. And so recognizing that that's being addressed but is not yet out, what I would say is that the reality is most of these patients is what we have currently found do have impairments. And so screening in some ways is unfortunately easier than we anticipate. 84% of the patients had impairments when we asked and spoke with survivors from 2 ICUs. And yet that doesn't necessarily give us a sense from hospital discharge who those patients will be 6 to 9 months later. And so while there are some tools that can be applied, and they are in the up-to-date card on intensive care syndrome that I had the pleasure of working with Jacka Washington and Gior Netzer on, we outlined with some feedback from other pioneers in the field, or experts in the field, I should say, that several simple tools, such as the Montreal Cognitive Assessment to assess cognition, the up and go test to get a sense of how well or not well someone is doing in terms of functional limitations. And yet, maybe what I'll conclude by saying is that each of these simple tools needs to be rolled out iteratively, and a challenge is who has the knowledge to see these patients in the outpatient setting to actually do what would be in general recommended. And I think that's one of the challenges, is raising awareness amongst outpatient providers and then encouraging them to serially test these and then provide them with strategies or rehabilitation opportunities to actually fight back against these new or worsened impairments.
Excellent. Dr. Moreno, are you on the line with us? If not, I'm going to ask Dr. Hernandez a final question. This is with regard.
Can you hear us? We are here from Bogota, Colombia. Can you hear us?
I can hear you, yes.
Okay, in the public, we have a question here for Dr. Murphy.
Excellent.
Okay.
Dr. Murphy, I have a question. What is the evidence, or what is the role for protective ventilation in healthy lungs like anesthesia or like non-pulmonary patients, or maybe it only works in RDS?
David, can you address that?
Could you hear the question, doctor?
We might have lost Dr. Murphy, but if it's okay with you, I can answer that question.
Thank you very much.
The data, excellent. The data is somewhat mixed. It is very clear that if you have healthy lungs and the condition for which you are being treated does not have systemic inflammation, then you don't need to use low tidal volume ventilation in that patient. You do, on the other hand, need to engage in lung protective ventilation that can be assessed by measurement of peak pressures, plateau pressures, and assessment of the pressure volume loop to avoid under-recruitment and over-distension. The real question is in the at-risk patient, the person who's being operated on for perforated diverticulitis, who does not yet have early ARDS, but is at risk. And in that patient, the data increasingly identifies that the early use of lung protective ventilation may be helpful in terms of ventilator-induced lung injury mitigation, shorter length of stay, fewer complications related to mechanical ventilation, and of course, reductions in the amount of analgesic and sedative that are provided, better patient and family engagement during the course of care, with a few early reports using modes like airway pressure release ventilation that strongly support that approach. It is not yet definitively identified in which patient you must do it this way and in which patients there will not be as much benefit, but perhaps that can be your next study to help us understand exactly how and when to use lung protective ventilation in those that are at risk as opposed to those who have established ARDS. Hopefully that addresses your question.
Thank you, Dr. Kaplan.
Thank you. I have one final question for Dr. Hernandez. You nicely articulated how to use ultrasound in evaluating weaning in the ICU. At this point, is this a technique that everyone should be able to use? And I'd like your perspective on whether we should be teaching this to our respiratory therapists as part of their evaluation of suitability and successful migration along a weaning pathway.
Can you hear me, Dr. Kaplan? Hello?
Yes, I can.
Yes, great. All right. So my answer to your question, I heard two parts there. One, should we be becoming more, I guess, comfortable with the technique? And two is whether respiratory therapists should be involved. So let me answer it in two parts. I think it's a tool like everything else. It provides information that we can certainly employ. In fact, when it's compared the frequency to tidal ratio to the less than 10 millimeter technique, there's not a whole lot of separation there. Now, when you compare it to the diaphragmatic thickening, there seems to be a little bit better predictive value there with the thickening. So there's some evidence perhaps to suggest that this might be beneficial to you. So I would say yes, it is another tool for us to become accustomed, and it is really becoming popular. As for whether other providers, in general, I think so. Definitely, we need to, this is a tool that should be used by everyone. There are different pathways where people are seeking certification. I know that's not part of the question, but these, the idea is that we want to have not just physicians, but advanced practice providers, nurses, if we start